Hi, everyone. Welcome to 107th Stanford MedAI Group Exchange session. This week, we have Zeljko from King's College London here with us to talk about his work on using large language models as universal medical forecasters. Zeljko is a researcher in AI for healthcare at King's College London, working on temporal modeling of patients and disorders using generative transformers. So Zeljko, thank you very much for joining us today. Before we start, do you have any preference on how you would like to take questions?
Thank you for having me. And I mean, anything is fine. Usually at the end is probably the easiest.
Okay. So everyone, let's keep our questions mostly for the end. And without further ado, let me hand it over to Zeljko.
Thank you. Okay, so I'll be talking about Foresight or large language models as universal medical forecasters. Before I start, let me set the scene a bit with what we wanted to achieve and why did we in fact do this, or why are we trying to use large language models and apply them to hospital and clinical data. Here, at least in the UK, a lot of the hospital data is kind of like locked away. It is very hard to access. It is very messy, very unorganized. A lot of it is in free text. I think like with some studies that we have done is like 80% of the data is in free text. And in a lot of cases, that data is not used like systematically, because imagine the knowledge that is contained in these hospitals where you have millions of patients and where you had like thousands or tens of thousands of doctors contribute to that data. All the knowledge that is contained inside is usually used in a way that, oh, we have a specific disease and we're just using a couple of blood tests and we are just like extracting a small portion of that data, 1%, and then running a small study on that. So what we were thinking, like, why not use it all? Can we somehow just extract all of that data and try to create one model that is a universal forecaster, so that is basically capable of predicting the future of the patient, irrelevant of what that is. So it's able to say what diseases will this patient have in the future, what are the medications that they might take, what are the symptoms they might have, and try to do it in a way that it's not predicting one step into the future, but try to have something that is capable of basically simulating the future of a patient for the next month, 2 months, 6 months, or even a couple of years. And how we have, like, what was the plan, how we have done this in the end, was to take the hospital record, extract all the information we have there about patients, and create something like a patient timeline. So what we do is basically take a patient, we create their timeline, and we know that this patient at age 68, they had restless legs. Then a bit later, they had hypertension. Then at 71, they had an X-ray and they had insomnia. So we basically are creating a timeline of everything that has ever happened to that patient and feeding that into a large language model, so the Foresight model. And then because, of course, generative language models can continue predicting into the future, they learn how to generate these timelines, and by that are capable of continuing or simulating these patients' future based on their past. We also wanted to add the option for a clinician or any healthcare professional to come and say, oh, but I would like to append some concepts to this patient timeline. For example, the clinician is thinking, should I give this patient the drug A or drug B? They can take this timeline, append the drug A, and then simulate the future, and then append the drug B and simulate the future. And basically see like which drug will cause, I don't know, either a better recovery or less side effects or anything like that. I've been here working mostly with around 4 to 5 hospitals in total. That is like 4 or 5 million patients. And most of these models, of course, have to be run inside of the hospital because we cannot take the data outside. Okay, so that was This is the final thing we wanted to achieve. Now, it took quite a bit of time to get to this point, and there is quite a lot of steps that were needed to get here. I'll jump over a couple of components of the system that was needed to build these, and then I will focus on Foresight itself. So, as I mentioned, the data is very messy. This is the example of the King's College Hospital in London, and it has basically like 10, 20, 50 different systems inside of it. The data is a bit of patient data is in every one of them. It is not really connected well. There is a lot of duplication. There is a lot of noise. There is a lot of everything you can imagine that like describes unorganized and messy data is usually here. And accessing these is very hard because there is no one point of entry where you can access all the data and where you can say, okay, I have the patient ID, patient 7, I want all the data for that patient. Basically impossible. So what we have done is we have created a system called CockStack. CockStack is basically a data harmonization engine. And what it does is takes all of this mess, processes all of it, connects all the right parts, so finds, like for the patient 7, it finds data from all of these systems for that patient, harmonizes it, organizes it, removes duplicates, does like OCR on documents where it is needed, organizes images, or does all of that and saves it into either a file server or into a Elasticsearch index. And Elasticsearch by itself allows you to like easily search through the free text and do whatever you want. But more importantly for us was it provides an easy to use, simple access API that we can now use to extract all the data about the patient in the hospital. So basically, once you are done with this step, what you end up with is just a giant table where I have the patient ID and then all the documents, all the information that belongs to that one patient. So in this way, now we have the data organized. But the problem is still that a lot of the data is in free text. That's, as I mentioned, it's around 80%. And there is a lot of duplication. There's a lot of information there that is not really that relevant. Some of it is like, oh, a nurse spoke with a patient and patient was saying like, oh, I'm not feeling too bad. My family was visited today. So like a lot of information is not really clinically relevant to that patient. And also a lot of those patients have hundreds or thousands of these documents, which even today's LLMs would have like a difficult time processing and finding the right information. So the next step was to create a medical concept annotation toolkit. It's called MedCat. It is an open source self-supervised model for extraction of biomedical concepts from free text. So after these data harmonization step and all of that, we now have documents organized per patient. And what we do on the free text is we run each document through MedCat, and then we get biomedical concepts extracted from that free text. Like on the image on the left, you see that an epilepsy was extracted, and more importantly, it was coded. It was linked to a biomedical ontology. So in this case, we have used SNOMED. SNOMED CT is just a giant biomedical ontology of like diseases, medications, symptoms, all of that. There are also, we do support others. I don't know if you know about UMLS or any one of those, but yeah, it's basically linking, extracting the entities, diseases, symptoms, medications, and then linking them to a biomedical ontology. This is a required step because in this way you standardize data. For example, you can have many different ways to mention the same thing in hospitals. So someone can, for example, for diabetes, someone can mention diabetes, someone can just write the abbreviation DM, someone can write T1DM. So there's like a million different ways to say this. And if you just extract the entity saying this is a disease, it doesn't really help too much because data is still like very unorganized. So we'll link it to SNOMED and by that it gets standardized. Next to this, for each one of the extracted diseases, you also get contextualization. This helps you basically know, like, is this concept negated or not? Like, it's very different if the medical record says this patient has epilepsy or had epilepsy, or this patient did not have or doesn't have epilepsy. So you get a couple of, so MedAI basically next to the extracted concept adds a couple of things like status, so is it negated or not, temporality, is it historical or not, and a couple of others basically that are very useful to have. As I mentioned, what was very important when building this tool is that ignore the formulas. This is not, it's not that important, but it's just to show that, like, what was important is that the model is self-supervised and that it basically learns to extract most of the knowledge is in fact learned by itself. So you let it run on one of these hospital EHRs and it learns embeddings for concepts. So after this pre-training phase is done, every concept in the biomedical database, which usually you have like hundreds of thousands of them, each one of them gets an embedding. And that's important because when later a concept, an entity is detected, like this HR entity here, we calculate the embedding of that entity based on the context where it was found, and then just run a cosine similarity against the embedding of all the concepts in the database and get what is the proper link for the HR concept. So in this case, if it was good, it would link HR to heart rate instead of hour or any other concept in the database. There is a bit of, so this is like 95% of the training is done in this way, but you still need a bit of fine tuning in the end, usually to bring the model up to speed and have it perform at like the state-of-the-art level. This model was trained and tested and validated for like over the last, I don't know, 3-4 years over millions of patients and a lot of hospital data and all of that. So it was done at KCH, UCLH, SLAM, the three big hospitals in London, and just showed that it really does work on all of them. We also showed like how to transfer a model trained in one hospital to another one. How do you do fine tuning? What is all necessary? Okay, so that brings us now to, we have extracted the data, everything is fine, but in fact, one crucial step was missing here, and that is anonymization of the data. Even initially, you cannot really even access data without it being anonymized. We don't want patient names to still stay in the documents. And while there are some models that already exist, we didn't have any that were properly validated on really this amount of data and on the hospitals in UK. So we created our own model. In general, it is a fairly simple model, like it just uses the transformer architecture. I think it's based on, it is based on Roberta Large, and it is fine-tuned on, I think, annotations from 3,000 or 4,000 documents across these hospitals. We have created a small ontology that is HIPAA compliant and also compliant with the UK government guidelines for the identification of health records. It's just an ontology, or because it allows us to easily control the granularity of the anonymization that we want to achieve. Okay, a bit of like experiences from training these models, because while it is very straightforward, what we found out very soon is that for these models, it was extremely important that the annotations are near perfect. You cannot even say like near perfect. You really want them to be 100% correct, because if you're doing standard named entity recognition, like missing a company name, no one really cares that much. But when you miss a patient name, the whole effort is wasted. Like you have anonymized 100 documents, but then the 101 has a patient name and that's it, you messed up. So the approach we have developed here, I didn't see it used too often. I don't think it's novel, but I didn't see it used too often. It's basically an iterative approach where we start with basically a data set selection. So we randomly select 1,000 documents. We have a group of clinicians annotate those documents and remove all the personal data. Then we train a model. And then what is important is we train the model on 80% of the data, test it on 20%, but for every disagreement between the model and the clinicians, so the annotators, we create that as basically a difference. We mark that. And then we again create a new data set containing only these differences. So whenever the model and the annotator disagreed, we have that validated again. Because in many cases, it is really a mistake by the annotator. The model has learned well, but the mistake was done by the annotator. So the model is correct, but the annotator is wrong. And then the annotators check all of the differences again. If all the differences are mistakes by the model, then basically we say, okay, we either need more data or we need a more powerful model because the model cannot handle the task. But if there are mistakes by the annotators, then the annotators fix those mistakes. And then we run the training again, we generate the differences again, and we basically run this procedure until all the differences are just mistakes by the model, or until there are no differences. Basically, like the annotators and the model agree perfectly, meaning the model has learned perfectly to de-identify these documents. So this was the approach we have used. It is a bit time consuming, takes quite a lot of effort, but it was the only one, sorry, it was the only one that we have found to properly de-identify these documents. And because in the annotation phase, if you have a document of 100 pages in front of you, try finding all the initials. Like it is very, very hard to do that. So it is good to have a model to verify what you have done. These were the results achieved after that. So if you look, for example, at our primary site where we have tested everything, the recall, which was the preferred measure, like if we overdo something a bit, so if the precision is a bit lower, it means like we have overdone the identification a bit, but it's fine. What is important is that we didn't really miss anything. And you can see that for most things, the recall is basically 100%, so it's 1.0. And again, initials are the worst one, but mainly because they were very difficult to annotate. In a lot of cases, it is just very, very hard to annotate the initials. And then we have that model transferred to another hospital and then checked the results on that hospital and then transferred to another hospital and then check the results. I'm basically just checking like what happens with the model when we transfer it, how much fine tuning is needed and how much additional work was needed. So we create a base model and then transfer it to other hospitals. And it was a good approach because we just found that when you transfer it to a new hospital, you usually need like 5% of the initial data set to bring it up to speed to have it work again very well. Okay, so at this point, we have all the components. We can de-identify the data, organize the data set, and extract the biomedical entities. So if you put all of these into one pipeline, that gives you basically the current Foresight pipeline. Once the data is extracted by MedCat, we combine it with the structured data, which can be things like ethnicity, sex, age, whatever else. And we order it into that patient timeline, we feed it into Foresight and use that to train the model. The ordering is basically done by the time of writing of a document. So if the document says like, oh, the patient came in today and he had a fit yesterday, then we would take that entity of fit or seizure and add it to the timeline based on the writing of the document, time of the writing of the document. There can be a bit of an error there, so we assume that it doesn't have to be that exact day, so someone can mention yesterday or tomorrow or something, but that is a mistake we are basically okay with. If the concept is really historical, we have the meta annotations, the contextualization from MedCat, which tells us, oh, this is a historical concept, so we know not to add it at the current time point. Okay. A bit more about the data preparation on the final step. So once everything is extracted, as I just mentioned, so we have all these concepts. The text is a bit tiny, but I hope it's readable. So we have all of these concepts now ordered. For each one, we have these T1, T2. That basically means the timestamp. So when did it happen? We do a bit of filtering and cleaning just because there's still a bit of messiness that is left. So for example, some of the steps are we remove concepts or diseases that appeared only once in the patient timeline. So if you imagine a patient EHR, if, for example, if they really had Stoneman syndrome, that is like a very rare syndrome, that would be mentioned 100 times in their documents. There is no way they have something like rare and that it's not mentioned in their documents very often, because it is for sure affecting their health a lot. So if something is mentioned only one in a patient that has 1,000 documents, it is probably a mistake by the NER and not really a real syndrome or a real disease they might have. So that's the first step of cleaning. There is a couple of other steps, but they are basically just there to remove noise or to remove any potential mistakes that were probably done by the tools earlier in the pipeline. In the last step, we do a bit of bucketing. So we group these extractions by day. Why? Because it is very often that inside of one day, the patient is visited by 10 different healthcare professionals if they are an inpatient. And it's very often that they will have the same thing mentioned 100 times. So if someone is in pain, it will be really mentioned 100 times. And that's basically like polluting the timeline a bit. So we group that by day and remove duplicates inside of one day. So if it's pain mentioned 100 times, we just keep the one mention. And what we end up with is a very simple timeline that is just like a comma-separated list of everything that has happened with that patient. I've shown it here as names of concepts, but normally weight loss will not be represented as weight loss, but really as the SNOMED ID for weight loss. Same for itchy skin, same for diabetes, and so on. So how do you now use these and feed it into a generative pre-trained transformer, so a GPT model? And why did we choose to use a GPT model to model these patient timelines? The reasoning is fairly simple. GPTs are causal, which was perfect for this case because, of course, if we use the BERT-like model that can look into the future, it doesn't make sense. It's a bidirectional model that also knows what is happening after a certain point in time. So we didn't want that. GPTs are perfect for that. We want a causal model that can generate the patient timeline. It is currently the state of the art for almost no matter what you do. Self-supervised, which means we don't need to do any training. It can extract the knowledge that is already in the patient data sets. And if needed, it is multimodal. We have X-rays, we have all the other types of data in hospital records. So we wanted to be able to ingest that also, not just the text part. The transition, like how do you change what is needed, what changes have to be done on top of a GPT model so that it can work with biomedical concepts instead of words. So if you look at a standard GPT model, what the task it's solving is at any point in time, I'm trying to predict what is the next word in sequence. What we have done is we simply removed the existing vocabulary of a GPT model and replaced it with a vocabulary of SNOMED concepts. So now our vocabulary was the 100,000 SNOMED concepts, or in fact, the IDs of the concept. So every concept is one token inside of the tokenizer. And then the task is very simple. Everything else is completely the same. We just run the model over these timelines and use it to predict the next word in sequence, or in our case, the next concept in sequence, the next disease in the sequence. And this is just to formally write that it is the standard language modeling objective, but instead of words, every one of the tokens is in fact a concept. So that's like, it is almost the simplest thing you can imagine to switch GPT model to be able to work with biomedical concepts. We have used 3 data sets to test this model and to train it. From King's College Hospital, around 13 million documents with around 1.4 million patients. We use South London and Maudsley. This is a mental health hospital. We have used only serious mental illness patients, 16 million documents, around 25,000 patients. And we've also used Mimic 3 just to have an open source data set so that anyone can replicate our results and test if we mess up something. The graphs are just, they basically show the length of the timeline. So how many concepts does a patient have in their timeline? It is tiny, but it is just showing that mental health hospitals have longer timelines than physical health hospitals. Okay, and these are basically the results. We have tested the model on, I think, 5% of the data sets, which in the end ends up with, I don't know, if you have 1.4 million patients, 5% is quite a bit of patients, so it's a large enough data set. The task is extremely hard because, like, imagine you have a patient for which in the timeline you have, let's say, something very simple. They have hypertension and you are trying to predict what comes next. It is very hard to predict what disease comes next just based off of the hypertension concept. So the model basically has a top one, so predicting one candidate, if it's correct, that's a positive result of 66%, which is like a very, very nice result. And top 10, meaning the model predicts 10 candidates. If any one of the candidates is correct, then that's a positive outcome of like around 92% in KCH and a bit higher in South London and Maudsley. And we have also validated, I'm missing, oh, okay, sorry. There is a slide that got messed up there. We've also validated this on manually created patients. So we basically had clinicians manually create 34 fake patients so that we can publish them and show people what we have done. And then Foresight was used to predict the top 5, basically do a differential diagnosis and predict 5 possible candidates. And then 5 clinicians have validated each one of those predictions. And we saw that in 97% of cases, at least one of the predictions was correct. So basically one of the differentials was correct. And in 88% of the cases, all the top 5 predictions, no, 88% of the top 5 predictions were relevant. So it is a very, very nice result when we were manually validating that. The results are slightly better when doing the manual validation because when you are doing this validation here, we require the model to be exact. So for example, someone might have, we really have to predict the exact disease and it cannot be any variation of that disease. So for example, if in the timeline, the concept is type 1 diabetes, but the model just predicted diabetes, we would say in this case, that's a mistake. But when a clinician is validating that, it was like, oh, okay, that's fine. The model just went one level up the hierarchy and predicted the more general diabetes concept instead of the more specific type 1 diabetes concept. So that's why this manual validation was in fact a bit better, or maybe a bit more representative of the real performance of the model. Okay, while we were doing this, we also understood there are quite a few areas to improve. And the first one was contextualization. Man, oh wait, I wanted maybe to first do the demo. Okay, let me first do the demo and then I'll come back to Foresight version 2 and the areas that, that we can improve. So I'll just show you briefly how does Foresight work, you can access it yourself and test it and play with it and all of that. On the right side, you are basically selecting what do you want the model to predict. You can do disorders, medications, symptoms, whatever else. You can select your model. So we have the KCH model that is primarily for physical health. You have the mental health model, and you have also the mimicry. A couple of other filters and all of that. If you really want to go a bit deeper, then have a look on the left side. There is a description for everything and how it can be used. You have a couple of examples here. So for example, you have the standard like COVID stuff. You just load that example, which simply represents a patient timeline. So we have a white female, 45 years old, and then a couple of diseases. And then more recently, they had loss of sense of smell, cough, and fever. And the model is predicting a couple of things, which is like still common cold is more likely for something like this, but it also does predict that COVID is one of the possible outcomes. We can also go like much more complicated and do like sleep apnea or a more complicated patient history and the disease, which in this case it will predict correctly as okay, obstructive sleep apnea, because this is a much more specified disease given these patients' history. Like we have more information and the model can be more certain in the prediction. There is also, if you want, you can also, you don't have to. So here you can add your concepts to this patient timeline, and I don't know, my diabetes, I can do that, or add a diabetic foot to this patient and then do the prediction or build my own timelines and do whatever I basically want. If you want to write text, that is also possible. So if you go here, you can just write a small like description of a patient. I think these examples were taken from BMJ, where they have like small examples of patients and their history or summary. So we just take that, copy paste, do the prediction again, and the model should correctly predict that, okay, this patient has Crohn's disease. Yeah, if you want to read more, everything is on archive. I wanted to just briefly also maybe show the medical concept annotation tool, which is simply you enter some text, click annotate, and you'll get your free text annotated with medications here or procedures or diseases and all of that. So just some examples, and you see that they have identifiers, they have status, which is it negated or not, and we even have like ICD-10 codes, and you have the confidence score that you can use to filter the outputs. Okay, and what I just wanted to see to show on Foresight was when you are doing the timeline and when you do your prediction, you also have a saliency, which is showing you what was important for this model. What did it use from this patient past to predict the future? And this is something I was also showing here. Is basically we know that to predict COVID, the most important concept was loss of sense of smell, which just gives us a way to interpret like, okay, is the model really doing the right thing? Because if it said that for COVID, most important thing is diabetes, then we would think like, okay, maybe the model's messing up here and there. Okay. So now I can go back to while we were doing this, you understood there are a couple of things that can be improved. First was contextualization. So in our current timeline, when you look at the concepts, they are standalone. If I look at the fall, I don't know anything about the context where this one was found. I don't know, for example, was it a severe fall? Was it multiple falls? Was it a light fall where nothing bad happened? So contextualization really gives you a lot of information about the concept itself. And this is what we have done to improve the model in Foresight version 2. Next to this, we have also understood that, okay, the Foresight version 1 is learning everything from the ground up. So it doesn't know anything. It is basically a new model, and we train it from the ground up. It has some advantages, but it also has some problems because the model has to learn everything. It knows nothing. It doesn't know what's diabetes. It's learning that simply from the patient timelines. And we were thinking, okay, yeah, but why not just use a pre-trained model that already has quite a lot of medical information in it, and then improve on the results. So in the new version, we now use a pre-trained Llama version 2. I've tested also Mistral, and I forgot the name of the third one, but Llama 2 was the best. I have no idea why. It is very hard to tell for these models why is one better than the other, but the whole procedure, everything was the same, simply Llama performed better. So it was not a lot. I think the difference was 1%, but simply it was better, so we picked this one. So how does the full process look now? Everything else is the same. The only thing is, for each one of these concepts in the timeline, we record the context in which it was found. So for example, here we have, for the loose stool concept, we also have the context, which is he reports having loose stools and losing 6.8 kg over a 3-month duration. And obviously, this is much more informative because without this, we would not know that the patient lost 6.8 kg. We would not know that this was a 3-month period where this took place and all of that. So it is providing significantly more information. So what we do now is after we have these timelines, we do a reconstruction of this timeline with embedded SNOMED concepts. So we basically take this concept, recreate now a clinical note that is basically a full-on summarization of the whole timeline of the patient with SNOMED codes embedded. And for the Llama model to be able to handle SNOMED codes, we do a vocabulary expansion, which means that we basically add the SNOMED concepts into the vocabulary. But this had to be done in a bit of a specific way because normally when you're adding tokens into vocabulary, you set the embedding of the token to be the average of the whole vocabulary. So the embedding of the token is the average of the embedding of all tokens. Here that didn't really work. The model was unstable. The training the loss didn't go down. So what we had to do is that for every concept that is added into the vocabulary, their embedding was set to the average embedding of the words of the name of that concept. So in this case, we would tokenize diabetes mellitus. We would do an embedding of that, and we would average over the embedding of each one of the tokens and set that to be the embedding of the new concept added to the Llama model. It's all in the paper if you want to go into more details, but it was necessary to stabilize the training. In any case, the training of these was not easy, to be honest. It took quite a bit of effort, and the model was unstable. We had to tweak the parameters quite a bit to get it right and restart the training off and take care of the losses and all of that. The loss function is again a bit modified. Now it is a modified supervised fine-tuning loss function when you do language modeling, because we only train the model to predict the SNOMED concept. So when the training is running, we don't predict any of the words. The model is only training on the SNOMED concepts, but of course everything else is used as the input. And this is a giant hill with a lot of results, but I'll just look at the first row. Basically, it performs much better. If you look at Foresight version 1, the accuracy for predicting any concept in the future was 52. The precision, was 52. Now it's 71. The recall was 32. Now it's 64. So it's basically like almost a 50% improvement on precision and almost like 100%, like almost doubling the recall from 32 to 64. So it is obvious, like it obviously benefits a lot from the context and benefits a lot from the previous knowledge, because 1 million patients is not a lot of data. Like if you look at how much data you need to train a model like Llama, 1 million patients is nothing compared to trillions of tokens that these models are trained on. So this is why I think like this model benefits a lot from something like this, because a lot of the medical knowledge is already inside, or a lot of the general world knowledge is already inside, and the model just needs to specialize for this domain of figuring out patient timelines. We've compared it to GPT-4 Turbo, and it performs significantly better on risk prediction. So what we do is we simply we took 100 patients and we are predicting the risk for these patients in the next month, I think, and comparing the performance of GPT-4 and Foresight. And Foresight is at 84, GPT-4 is at 62, which does make sense. I mean, GPT-4 is not a medical model. Even the 62% is an awesome result, given that I don't think it has seen millions of patients the way that Foresight has. But it's also just tells like how difficult this task is. Predicting, this was also done on a data set of A&E patients, and predicting what will happen with an A&E patient in the next month is extremely difficult. They can have like 20, 30 new diseases that appear in that month, and that's like very, very hard to do. And in this table is just some examples of prompts. So for example, older male patient with obesity and sleep apnea recently increased somnolence and dyspnea, liking a sign of hypercapnia, which is the correct prediction. So it is just showing how to prompt these models. This model is similar to like GPT-3, not really ChatGPT, because the prompts have to be a bit specific. You cannot just chat with it. You have to write a specific prompt that the model knows about. Okay, utilities, risk prediction, diagnosis, digital twins, stuff like that. Challenges. It can only do what it has seen in the data set. If a disease has never appeared, it cannot predict it. So that's fairly standard. Cannot accurately estimate time. It's still, the models are not good with numbers, as we know with GPT-4 and basically any other. So time is a bit messy because it's a number. And it learns a bit of the biases in the data. And I'll show you just one last thing very quickly, which is the final version of Foresight 2, which is a full-on model that is like, we start with Llama, then we fine-tune it on medical guidelines, textbooks, and all of that to get it better, to like remove the biases. We want that core knowledge, core medical knowledge. We fine-tune a model, call it NHS LLM. We then run the semi-supervised training on hospital EHRs, so on these patient timelines. And at the end, we run a reinforcement learning from human feedback to finally fine-tune that model for the full-on version of the Foresight V2. And the final picture is just how this NHS LLM looks, which is a simple model that is simply trained on medical guidelines and textbooks, and you can ask it questions in the same way you can do with any other chatbot. But what's the difference is that it quotes the references. So it will tell you, oh, this was found on the NHS website, conditions, headache. So you have, the knowledge doesn't come really out of the void, but it's really telling you like, it's giving you a reference where and how it got to the answer. And that's all. Thank you very much for listening. If you have any questions, I'm happy to answer. On the left side, we have the full team that was part of this.
Thank you very much, Zeljko. This was very interesting talk. So before we open the floor for questions, let's give our speaker a virtual round of applause.
Thank you.
And if you have any questions, please feel free to ask.
I can get started with one.
Sure.
So very great to see the effort on doing this specifically for medical concepts and like especially predicting the future risks for patients. But I saw in your demo that you had one for mimic, one for, let's say, a different hospital, and like you had Are those essentially different models that you're running for each data set? And if so, do you feel like forecast you will have different versions where one is maybe more for mental health, one is more for physical? Is there a way of, like, is the goal to unify everything in one model, or do you see it as being more separate?
I feel unifying everything as one model is the optimal outcome. Why was it not done? Because we could not combine all the hospital data in one place. Because we had access to many hospitals, but we have to go there and train there. And the thing is, like, if you just take that model and transfer it to another hospital and then continue the fine tuning, it forgets quite a bit of the old one. So, I mean, it would be awesome if there was one place where we would have all of this data and then we can train it on everything at once.
I see. So the practical challenges of like different hospitals not really having the same type of data kind of makes it like you have to do it on a per hospital basis. Is that correct?
Well, it is just because we cannot, like, it would be awesome if I could take the data from one hospital and bring it into the other, or if there was one place where I can harmonize all the data at once, but we cannot. Like, hospitals here at least don't share the data, so you cannot share data between hospitals. It's just like, doesn't make any sense. But it should be awesome if I could take, for example, this KCH hospital and take data from SLAM, take data from all the other places, and then just train on everything at once. But yeah, hopefully in the future.
Makes sense. Thank you.
Thank you so much for the call. Can I ask a question?
Sure.
Yeah, of course.
So if we want to add, let's say, the medical imaging or radiology reports to the system, which I think right now you only have EHR, right? So
Sorry, yeah, go ahead, sorry.
I just want to know in your diagram that you showed for the whole system, how you're training. If you go back to that slide and we want to inject now this medical imaging, I mean, it could be just reports, it could be also images, then where should we inject them?
Okay, so we are already using reports. So basically we use all free text that we can find in the hospital. This includes really radiology reports or anything else that exists that is in free text. Or in the future, once we get access to images, then the easiest way is simply to, this is again the way how LLMs normally do these things. You either have the option of take an off-the-shelf model that is pre-trained already to process medical images and simply append those images in that patient timeline. And instead of having that image as a token, run it through that image model and then add that as another token in this patient timeline. So it will simply be another token in this timeline of events that are happening. And of course, we would not be able to predict it. It would just be another input token. Or the other option is what I prefer and what I've seen a lot with the recent LLMs is where these images are appended as basically like stripes into the patient timelines as full-on tokens, and then the model learns to process text and images all at once, which is just, to me, is a cleaner approach. But yeah, all of these would be added basically during this training step into the patient timeline, and then an LLM would be trained on that. If that answers your questions, I hope.
Yeah, I think I joined a little bit late. And so what is the MedCat doing here?
Oh, okay. MedCat is the medical concept annotation. So what it does is extract these SNOMED concepts. So from the free text, it extracts diseases, symptoms, medications, and all of that, and puts them into the patient timeline.
Got it. So if I want to do it on my own, what you have done, is it feasible on a few GPUs I have? Let's say.
Yeah, very much so. Yeah.
Okay. So if I just want to apply the same thing on pharmaceutical applications and I have the data for that, can I train it on like one GPU for how long it takes to train?
Okay, one is undercutting it a bit. One would take a bit of time. You would probably, 8 GPUs, like 8 A100s, one DGX machine or something like that would be enough to train this
For how
in
long?
like a couple of weeks.
Couple of weeks. Okay.
Yeah.
And what is the number of training data that you have right now? Like how many reports, how many EHR?
So we were working in total, I think, with around 40 million documents. So 40 million documents from the patient EHR.
Do you have any like knowledge of like in what stage or what level of data it start to make sense? So if I get this Llama 2, which has no idea about medical stuff, and then I start to have a million data points, and I want to know at which stage it makes sense. It gives you some information.
So it depends how much additional data you plug into it. If you already plug quite a bit of medical data into these models, so if you find medical textbooks, guidelines, and if you want to go to pharmacy, then you find maybe informations on medications, leaflets, whatever you can think. If you further train the model on that, then you don't need that much more data to make it proficient on these patient timelines. Then I think the smallest I've seen is around 30,000 patients to get decently good on the prediction of patient timelines. If you already had ingested quite a bit of medical data. So like Llama 2 would not work, but there is one model called like N42 or something like that, I think, which is a biomedical LLM. So if you have that and you continue fine-tuning, it will work better.
So in this diagram, where is Llama 2?
Here, the first one. So basically the general model that is trained on all of internet is the first step.
If I want to just train a model for a pet, like for a vet, let's say application, what should I change here?
I mean, the only thing you would need to change is basically the creation of patient timelines. I mean, I don't know how or which timelines would you have in pharmacy, or how would you do that in pharmacy, but you would basically, the only thing you would change is this part here. If you have a timeline of, for example, patients taking certain medications and then checking adverse reactions and all of that, so if you would have such patients, then you would create these timelines here, and that's it. That would be the only change that you would need to do.
And maybe the context, like the medical knowledge, right? It should be also.
Yeah, it would be good. Yeah, it would be good then to like not just have medical guidelines, but you want to have information about drugs.
That's great. But you said that, so guys, if I'm talking too much, just let me know. But if you want to have a conversational model out of this one, like what we should do. I know that you have an RL at the end. Is it conversational?
Yes, that's the part where you would go to conversational.
Got it.
Okay. I think we can, well, if it's okay, we can probably connect you to offline.
Yes.
If you have
Oh yeah, of course, yeah.
I appreciate it.
Yeah.
Okay, so if any of our audience have any questions, please go ahead. If not, then I have one little question about how, and you mentioned that time is kind of difficult for these LLMs, but when you create a timeline, is there like spacing differences between like how far apart different concepts are? Like something is historical, something might have happened 10 years ago, and then things might happen like each day if you're in a hospital.
Yes, the timeline, in fact, does contain like the patient age. So we know, I don't know, if something is 10 years in the timeline, we know the patient was, I don't know, 57, but it also contains these separators. Here I'm showing only one. but in fact it has like these temporal separators. So one is separator 1 day, one is separator 7 days, one is separator 30 days, one is 365 days. So basically these separators are telling the model, oh, now 7 days have passed and this has happened, or a year has passed and this has happened. So it has a bit of, but that's why I'm saying like it's not that accurate, because it will predict, oh, 30 days has passed, but that can also mean 35, it can also mean 21,
It's
it
a
can also mean
quantized
60.
concept of time, most likely. But
Yes.
one thing, like I think your MedCat had the capacity of figuring out if the event was historical. So, like, let's say
Yes,
somebody
yes.
had a heart attack 10 years ago, right? So, how exactly, like, so are these separators, like you have some separators for like 1 year, 5 year basis as well? What do you do with
So in this
historical?
case, yeah, if it is marked as historical, we would not even include it.
Oh, okay.
If it is just like an old concept, something MedCat marks it as historical, then we would not include it, because we wanted only the new concept. There are in fact two versions of this model. One is with these historical concepts excluded, and one is with the historical concepts included. What in fact works better for the Foresight version 2 model is to include the historical concepts. Why? Because based on the context, because I know the context here. So even if I say age 74, false, but if the context says like, oh, they had false 7 years ago, it is already clear to the model. So in the Foresight version 2, basically even historical things are added, and from the context, it is clear to the model when did it happen. In the version 1, we didn't have that, so we had to either remove them or simply just leave them and hope for the best.
Okay. Yeah, I think the idea of adding concept, sorry, the context is like, and your results are also showing like 20-30% improvement. I think that's very informative. One question about your last, the latest version that you were showing, in that you have the knowledge induced from knowledge databases like medical guidelines, textbooks. So how are you, I mean, you just training on this one, as in like mass token prediction, next token prediction, next word prediction, or do you have any specific kind of knowledge injection techniques here?
It is knowledge injection. Even here, the training goes through like this framework that's called OpenGPT that we have made, I think, last year. And what does this framework do is like creates conversations like between a patient and a doctor, grounded in a guideline or grounded in a medical leaflet. So if I have a leaflet about diabetes, then I would take that leaflet, feed it into a model like GPT-4 or whatever, and then ask the model to create me something like a conversation between a patient and a doctor based on that medical leaflet. So I would have basically a conversation that is now very, very medical and very much based in that medical guideline. It's not just a random conversation between a patient and a doctor generated by GPT-4. So yeah, something like that is used basically as a bit
then you use
more
that conversation or like those sets of questions and answers to basically do this knowledge injection, right? So if the model is able to predict those answers correctly, that's a way of knowing that model has now been injected with the knowledge of that guideline or that leaflet.
Yeah, and this is where we show just it works. Like this the NHS LLM is just basically was an intermediate model. We just showed that this knowledge injection in fact does work, and it is citing the proper references, and even the answer is really the answer you would expect from this guideline that is found here. Not guideline, but leaflet.
This behavior of citing references, it's coming from the conversations, the medically grounded conversation set that you have generated. So, okay, in that, there's a common behavior for citing the reference.
Yes, yes, exactly.
Makes sense. Let's, if anybody else has any questions, please ask. Otherwise, I think we're already slightly over time. We can wrap up. Okay, so everyone, let's give our speaker another round of applause. Zeljko, it was a very informative presentation. We will be posting this on YouTube. I believe the contact for our presenter would be there if anybody wants to connect with them offline. Thank you very much, everyone. See you all hopefully next week.
Thank you. Bye-bye.
Yeah.